Good afternoon.
Afternoon.
My name's Dr. Farrant. Are you Mr. Williams' daughter, is that right?
I am, yeah.
Okay. And I believe you wanted to come and talk to me about how your dad's doing today, if that's all right.
Yeah, I just have a few questions I wanted to speak to the consultant about.
I'm the registrar who's looking after your father at the moment. The consultant's not here. I can try and answer some of your questions if that's all right with you.
Yeah, if you can help, that's great.
Yeah, that's fine. Before we start, I just want to confirm you've had permission from your father for me to talk to you about all of this today. Is that right?
Yeah, I'm his next of kin, so he's given me full permission to talk to you. He's obviously he's not really well enough at the moment to hold a conversation, so he's confident that it's best that I take the information in and feed it back to him.
Okay. And how much do you know about your father's condition and where we're up to with him at the moment?
Well, obviously he's got cancer. I know that, and he's very, very ill. He's very uncomfortable, very poorly, and I suppose we're all all the family were quite aware that it's just a matter of time, really. Yeah.
Okay. And are you aware about our plans for what we will do if he gets more poorly?
You mean the
do not resuscitate?
Yeah, we're aware of that.
You're aware of that, and you're happy that that's in place?
Yes, that's what my father wants, and
okay.
I think that's the best thing for him.
And so yes, he has got cancer, and he's very poorly at the moment, as you can see and as you've said.
Yeah.
And I think we're, after seeing the deterioration that's happened in him since he's been admitted, we can see that he's unfortunately nearing the end of his life now.
Yeah, I'm aware of that. I just wanted to see if there's anything that can be done to sort of manage his pain a bit more. He just seems really agitated, and I'm just finding it really difficult to see him in this state at the moment.
And that's normal. Okay. It's never nice seeing a loved one in this sort of a situation. Okay. And from our point of view going forward now, our focus needs to be on what we can do to keep him as comfortable as possible, as opposed to actually actively treating him. Okay. So we're not trying to treat his cancer or treat any of his conditions. We're trying to deal with the symptoms and make him as comfortable as possible. Okay. So you mentioned the pain.
Yeah.
So at the moment he's on a morphine patch, all right.
Mm-hmm.
And it's important now that we're sort of switching to a palliative approach, that we look at that in more detail, because if we're not controlling his pain, there's lots more things we can add in. All right.
Okay.
Given that his level of consciousness isn't good, I don't want us to be doing that in tablet form, obviously. I don't think he would be in a situation where swallowing tablets and things like that are going to be appropriate for him.
Okay.
So we'll be thinking about things like an infusion of pain medication through a syringe driver.
Like a needle?
So essentially it's a needle that just sits under the skin, and it's attached to a syringe that's got a makeup of medications in that it's constantly going to be giving him, okay, to give him a good amount of pain relief.
So it stays there all the time?
Yeah, so he'll be attached to it. Also, I'll make sure we prescribe some more as required medication, so that if that syringe driver is not giving him enough, the nurses have the ability to recognise that and give him a top up.
Okay. Well, I've been aware that he's quite uncomfortable, and I know he's not had a bowel movement for a while now, and I'm just wondering if this is adding to his discomfort at the moment, and if there's anything we could possibly do about that, just to make him more comfortable.
Yeah. From a bowel sort of perspective, it's slightly difficult in that if we're worried about his swallowing, giving him things by mouth is a bit more difficult. Okay. So what we can do is we can use things like enemas to try and help clear things out from the back passage perspective, but I don't want us to be pushing too hard with tablets and things like that, because I don't think his swallow's safe to be doing that at the moment.
No.
All right. Equally, if he's in pain, then I think really the thing to do is to give him more morphine and try and control his pain better from that, to try and give him a bit more comfort. Okay. Also, you mentioned that he's quite distressed and agitated.
Yeah.
So we have some other medication that we can add into the syringe driver called midazolam to try and deal with his agitation at this difficult time. All right. Okay. That should help to keep him calm. All right. And help to deal with the distress that he's clearly in at the moment. All right. Also, we'll be keeping an eye on him for other problems, like if he starts getting difficulty with his breathing, we can give him some more morphine type medication. If he's having lots of secretions, we've got medication to dampen that down. We've also got medication we can give to deal with any sickness that he might be dealing with. Okay. If he becomes more breathless from the mesothelioma, then we can give him some oxygen just for a bit of comfort as well. Okay.
Okay.
One thing that people normally ask in this situation is, how long are we looking at?
Yeah, I did want to bring that up. Obviously, we have family up and down the country who, obviously would like to come in and see Dad. I don't know if it's possible for him to have some visitors over the next few days, or do we even have that much time? I don't know.
So I've been right lots of times and I've been wrong lots of times, and so I never like giving a cast iron guarantee on how long we have left, because it doesn't work like that. Okay, but what I would much rather you do is let people know and give them the opportunity to come, than us say it'll take a week, or we've got a week left when we may not. So I would suggest, now that he's quite poorly, letting people know and giving people the opportunity to make their own decision and come down if they need to and they feel that that's something they would want to do.
Okay. And just in terms of, again, just trying to make things a little bit easier for him, I was just wondering, obviously he's not really able to eat very much, but can I perhaps bring him something homemade, some homemade soup, something like that? Would that be possible?
So if he sort of regains consciousness to the point where he can eat, then I have no problem with him having some home comforts. But equally, he is very poorly at the moment, all right? And I don't want us to be giving him things if his swallowing's not safe and his conscious level's not good enough for that, because that could make him more distressed. I don't want him to aspirate and soup and things to go into his lungs, because that wouldn't be very good for him. No, so of course. I think we just need to see how he gets on over the next 24 hours or so. If he gets a little bit better, then that's something we could look at.
And I also wanted to ask, a few days ago, obviously he's got his fracture in his spine as well that he's having to cope with. But the nurses managed to sit him up a little bit. And when he was sat up, he seemed to have, I don't know, just a little bit more brightness about him. I mean, I was just wondering, is there any way we can do that without obviously causing him any pain? But it just gave him a kind of something, a bit of something,
Okay. So yes, I think we can sit him up. Now that we're in a sort of a palliative situation and we think he's nearing the end of his life, it's less of a concern about the risks to his spinal cord and things like that from sitting him up with this back fracture. But I don't want us to just be sitting him up too much, so I think we should do it gradually and see how his pain responds to that. Okay. So just to summarise, obviously your dad's very poorly. We're switching his sort of treatment aims now to an end-of-life treatment plan. We'll be treating his symptoms and not his underlying condition. Okay. And I think it's a good idea now that if there are family members you want to give a call and ask them to come and see him, now will be the time to do so.
Thank you.
Thank you.
The ICE and SPIKES models are well-recognised frameworks that can be used by candidates in communication skills, and it can help you frame your discussion for breaking bad news. SPIKES can be split up into step 1, setting. Make sure that you're in a private setting and invite the daughter to bring along someone for support. Before meeting with the relative, you will have already confirmed that you will have the patient's consent to discuss their case with the relative. Step 2, perception. Use the before you tell, ask strategy of starting with an open-ended question, such as, "Thank you for meeting with me today. My name is Dr. X. So, we are meeting today to discuss how to best manage your father's condition, and in particular his pain control relating to his cancer. But I just want to start by establishing what you understand about his condition presently." The response to this open-ended question will allow you to determine how much the relative understands and at the same time offer the relative the opportunity to pose questions to you. Step 3. Invite the relative to express how much they wish to know. Examples of questions asked to the patient would be: sometimes patients and relatives want to go into detail about the management of their care, and other people would prefer to focus on the specific points. Before I start, I just wanted to establish what you wanted to discuss and how much detail you would like me to go into. Step 4. Giving knowledge. Unfortunately, I've got some bad news to tell you, or I'm sorry to tell you that. I'll just run through 4 important points to consider. Point 1. Pitch the discussion at the level of comprehension for the daughter. Point 2. Make sure that you use non-technical information. Point 3. Give the information in bite-sized chunks rather than all at once. And point 4. Periodically check the person's understanding. At this point, it would be appropriate to discuss specific end-of-life issues. Introduce this by saying something along the lines of, when patients have terminal cancer and are nearing the end of life, there are specific targets for treatment that we try to address preemptively. To counteract pain, we prescribe medications that sometimes contain morphine. If the patient is unable to take this by mouth, then we can give this by injection, or sometimes via a pump, to keep on top of pain. One of the side effects of morphine-based painkillers is constipation, and so to avoid this, we usually prescribe laxatives to keep the bowels regular. Agitation is also common, and we will prescribe medication that can be given in case this occurs. Regarding the daughter's concerns about the father suffering and speeding things up, you need to explain that although there is nothing that can be done to speed things up, one of the side effects of morphine-based medications is something called secondary effect, which is that some of the medication that helps with pain control can in turn slow the breathing. Step 5. Addressing the emotions and offering an empathetic response. In this case, the daughter is concerned about the prospects of her father's suffering, and certainly for a long period of time. Although you can't offer precise details, explain that when patients are less rousable and as poorly as her father, we are probably talking in terms of days to short weeks at the most. Step 6. It's time to wrap up with a strategy or to summarise. Patients or relatives who have a clear plan for the future are less likely to feel anxious and uncertain. Before discussing a treatment plan, it is important to ask patients if they are ready at that time for such a discussion.